I'm Trish Robbins.
Hi, my name is Michelle.
I'm Imperial.
And I'm Imperial's mom, Megan.
Hi, I'm Laura from Argentina.
I'm Stacy.
Hi, I'm Melissa.
Hi, I'm Jenna.
Hi, I'm Cheryl.
Hi, I'm Jane.
I am Maurice Lanier.
I was diagnosed with DRESS syndrome in June 2021. My reaction was caused by clindamycin and Bactrim for an infected finger.
I first experienced DRESS in 2016, but it went undiagnosed. 2025, I was finally correctly diagnosed. My DRESS syndrome is caused by all insects.
I developed zooepidemic-induced DRESS syndrome in 2020.
I developed DRESS syndrome 2 months ago from sulfasalazine. I'm still tapering down on the prednisone.
I was diagnosed with DRESS syndrome in May of 2024 from clindamycin.
I developed DRESS syndrome from lamotrigine in 2019.
Well, I got DRESS in February of this year of 2025, and the culprit was vancomycin.
I developed DRESS syndrome back in January 2024 due to lamotrigine.
And we're the faces of DRESS.
I am the face of DRESS.
I am a face of DRESS.
I am the face of DRESS syndrome.
I am a face of DRESS.
I am the face of DRESS.
I'm a face of DRESS.
I am a face of DRESS.
I am a survivor. My voice, my mind, and my strength endure.
Well, hello everyone and welcome. We are so grateful to have you here with us for this virtual event today in honor of National DRESS Syndrome Day. I want to sincerely thank everyone joining us, whether you're a survivor, a caregiver, a clinician, or just interested in DRESS syndrome. Your presence here is very appreciated. This year's theme for National DRESS Syndrome Day is Faces of DRESS. It honors the patients, families, and medical professionals that are impacted by this life-threatening condition. And our goal today and throughout this campaign is to raise awareness, share real stories, and foster a deeper understanding of DRESS syndrome among the public and medical communities. We'll hear today from those in the medical community who are doing great work in the field of severe adverse drug reactions, both research and patient care. And we'll hear from those who have lived through DRESS as patients and caregivers. And I want to say a huge heartfelt thanks to our speakers for their generous time and to our incredible team behind the scenes, Deanna Loriani, Ava McKinney, Raymond McKinney, Chris Henson, and Chris Smith. We are so grateful for your help in making this webinar possible. So before we dive in, I want to tell you quickly who we are. So I'm Tasha Tolliver. I founded the DRESS Syndrome Foundation in 2019 with the support of family and friends and another mother who, like me, lost her daughter to DRESS syndrome. I see the work we do here at the foundation as a way to really honor those who didn't survive this condition and to provide hope and support and better care for those who are affected by DRESS. I am joined today by our Communications Director, Deanna Loriani. You'll hear from both of us throughout this event as co-host. And let's tell you a little bit about the foundation. So we're a nonprofit. We're based in Richmond, Virginia, and we're a growing collaborative network of patients, families, researchers, and physicians, really from around the world, who are committed to supporting those affected by DRESS. We focus on education, advocacy, and research with a vision of a future where severe drug reactions like DRESS are predictable, recognizable, and treatable. And now I will turn it over to Deanna. You're muted, Deanna.
Sorry about that. It's so wonderful to be here today. Thank you for joining us on National DRESS Syndrome Day, which is today. This is an annual holiday that we created that takes place worldwide on July 16th each year. The goal is to raise awareness about DRESS syndrome and to bring visibility to the people who are impacted by this condition. It's also a day to honor the researchers and the medical experts and the clinicians who are doing great work to better understand DRESS and treat patients, as well as the patients themselves, the caregivers, and the loved ones whose lives have all been impacted by DRESS syndrome. And so we are hoping to help share their stories. This year, the theme is Faces of DRESS, and to share the people behind the condition and everyone who's doing the great work of diagnosing, treating, researching, and surviving this complex condition. We're really excited about today's lineup. We have a great speaker panel full of leading clinicians and researchers in the field of drug hypersensitivity, and individuals and families who've directly experienced stress firsthand. And everyone brings a unique and vital perspective to this conversation. You'll hear stories of courage, insights from emerging research, and discussions that we hope will inform, support, and inspire you. And starting today is Dr. Elizabeth Phillips. We'll begin today with Dr. Phillips, and she's of Vanderbilt University Medical Center. Tasha recently had the opportunity to sit down with Dr. Phillips and talked with her about a Q&A on some of the most frequently asked questions surrounding DRESS syndrome. And just a quick note that this is an excerpt of a longer discussion they had together. So we'll be showing a little bit of it today, and then we'll make the long version of their discussion available for future viewing. So let's go ahead and take a look.
Oh, hi, Dr. Phillips. Thank you so much for taking the time to answer the common questions we hear from patients, families, and medical professionals about DRESS syndrome. As someone who talks with DRESS patients and families every day, I can tell you that these questions come up again and again. So I know your insights will be incredibly helpful. To get us started, could you introduce yourself in your own words? And then could you give us a brief explanation and description of what DRESS syndrome is?
So, hi everyone, it's really, and thanks Tasha for the opportunity to speak here and answer some questions on National DRESS Syndrome Day. I'm Dr. Elizabeth Phillips. I direct the Center for Drug Safety and Immunology at Vanderbilt University Medical Center, and my passion for the last 30 plus years has been the medical care and research of patients with severe cutaneous adverse reactions like DRESS. So a question that Tasha asked me to open up with is actually define, I guess, what is DRESS. And DRESS is an acronym. It stands for Drug Reaction with Eosinophilia and Systemic Symptoms. It is a fortunately rare but serious event that is occurring after specific drugs. And when I say specific drugs, the top 5 drugs that cause DRESS have not really changed considerably over the last 15 to 20 years. And these include things like sulfa antibiotics, such as other antibiotics like vancomycin, such as anti-seizure drugs, and allopurinol. So DRESS is a delayed reaction, which contributes to sometimes the diagnostic uncertainty because it doesn't happen right after a drug is started. It takes generally about 2 to 3 weeks on average, but out to 6 weeks. And it's characterized again by symptoms that can be a little bit hard to differentiate from flu-like illness or other symptoms. So it starts with fever, and then most often it does have a rash associated with it that progresses over time. It can have swollen lymph nodes, and then varying degrees of body organ involvement, which may or may not have symptoms associated with them, which is part of the trickiness of DRESS. And healthcare providers have to think of this. They have to assess the patient, and they have to order the right tests in order to actually diagnose DRESS. DRESS is defined by various scoring systems that are designed to enable a more precise diagnosis of DRESS, and one of those is only used that was defined by the European group is called the Registrar score. That's also an acronym, but the purpose of these types of scoring systems is simply to assemble different symptoms and signs and help healthcare providers to be able to actually think of DRESS and come up with a diagnosis of DRESS.
Thank you, Dr. Phillips, for that thorough explanation of DRESS that really helps set the stage for the questions to follow. So let's just dive right in and tackle the first question, which is, why is it so difficult for healthcare providers to recognize DRESS early on?
I touched on some of this in my definition of DRESS, in that fortunately DRESS is not very common. And when I say not very common, for the drugs that are most likely to cause DRESS, it may only occur in 1 in 1,000 to 1 in 10,000 courses. And what this means is it's something that healthcare providers are not going to be seeing very commonly. They may not get appropriate training on this when they go through medical, pharmacy, nursing school, etc. So thinking of a diagnosis means having it at your fingertips. And I think this is part of the problem. But the other issue that I touched upon is very early, the symptoms of DRESS can be non-specific. And what that means is it can start with just feeling unwell, having general malaise, or having a fever. The rash can come later, and other symptoms like lymph node swelling may be mistaken for a viral infection, and the other things that define DRESS, like the organ involvement and the blood abnormalities like the eosinophilia, may be hidden unless the provider thinks about them and orders it. But I think the most important thing is when it comes to DRESS and thinking about DRESS is, number one, there's a drug involved, but the drug has been involved distantly because these are delayed reactions. And so the drug may have been started 2 or 3 weeks ago. So it's really important for providers to go through thoroughly and take a history and a timeline of all drugs that have been started within the last 6 weeks. Stopping every drug that could be possibly implicated in DRESS is the most important thing a provider can do.
Can you just touch on for a moment the timeline in terms of how long after recovering from the acute episode of DRESS can a patient expect these long-term complications to show up?
I think we need to understand a lot more about that. And so the longitudinal studies that have been largely been done, the long-term studies from Japan and Europe, now suggest that patients can have complications greater than 5 years, and about 15 to 20% of patients might experience those complications. We do think from recent Japanese studies in particular that some of these long-term effects that we thought were over in the first 5 years can occur even 5 to 10 years or longer after DRESS. And so the monitoring needs to be kept up.
That's so important. Thank you. Switching gears here a bit, let's talk about genetics and DRESS. And the question is, why isn't there one clear DRESS gene that tells us who is at risk before they take a medication?
So that's a great question, and clearly it would be nice if it was that simple. Specific immune responses are specific to individuals, so that we all make responses to infections, and our immune system matures over time, and these types of responses are very specific to our cell and are driven by our genetics. But when a specific drug that has a specific structure is introduced into the piece, that specific drug we think can alter a protein in the body to look very much like a protein to which the body made an immune response decades ago that looks like a virus or looks like a piece of a virus. And that is what we think triggers the actual specific response to a specific drug. And so the genes that trigger the DRESS syndrome, like other immune-mediated reactions like SJS/TEN or Stevens-Johnson syndrome, are specific for the specific drug. And more complicated than that, because we've evolved over continents and different geographies, that a specific gene that drives DRESS to a specific drug in China or Taiwan may not be the most common gene driving that reaction in the United States.
Let's talk about families and risk factors. If someone's had DRESS and carries a known risk gene, what are the chances that their child or sibling or other close relative also has that gene? And if they do, how likely are they to develop DRESS themselves?
This is a common question that gets asked, and I think it's that this is the first thing people want to know if they've had a serious reaction is how likely is harm going to come to a close relative based on, the genetic risk associated with their reaction. And stress and other delayed reactions seem to be mediated by the human leukocyte antigen, HLA, which is a type of gene that, again, has been an integral part of our evolution. And so the reason for that system, which is under the MHC or major histocompatibility complex, the reason for the evolution of that system was really so our bodies could tell self from non-self, from foreignness, from self. And so we could actually respond appropriately to invaders like viruses and bacteria, but actually not attack our own proteins and not produce autoimmune disease. And so that the importance of understanding this is that these genes are inherited in a slightly different way than other genes. If a parent or a sibling carries a risk gene, the chance of a child or a sibling carrying that risk gene, given that they only carry one copy of that risk gene, would be about 50%. So it's significant. But if you carry a risk gene, your chance of developing DRESS or SJS is still very small. So it's not 100%. In most cases, it's less than 10%. We don't know if a family member has had a reaction, if another family member is more likely than the general population, but we think that those types of ratios are still very low. So if a family member carries a risk gene, their chance of developing DRESS or SJS with that drug is still going to be very low.
Thank you. I think that's really helpful for families to hear because it's certainly a huge concern. And another thing patients often tell us is that they feel very anxious about taking medications, any medication after DRESS. How can healthcare providers help patients feel safe again? And who can guide them on which drugs are okay for them to take in the future?
It's often hard to find someone early on to really have a crucial conversation with a patient and go into all the details, the knowns and the unknowns. But I think that having that conversation as soon as possible, it's a bit like getting back on the horse, right? It's like having a very clear conversation as soon as possible is extremely important. What we do know is that the actual reaction that occurs, the immune reaction that occurs, is very specific for the drug, is often mediated, whether we have discovered it or not, it's often mediated by a specific HLA gene. And getting that kind of early risk stratification and conversing with the patient about which drugs are safe for them to take and which drugs they should avoid is really crucial to do that as early as possible, because I think having that confidence and having that conversation early on really sets the stage for everything else that happens. Although we are still evolving in the tools that we have available to us to actually define which drugs will be safe in the future, in terms of there obviously are drugs that look similar to other drugs, a conservative conversation can be had with a patient to say, look, these drugs are nothing like the drugs that you actually, or the drug that you took, or drugs, if it's uncertain of many drugs at the time you had DRESS, and there's no reason why you can't take these other antibiotics or these other anti-seizure drugs. These are the ones that we're going to place on your list as safe to take, and these are the ones that you should avoid. And so I think the reason that doesn't happen early enough is because it's a question of which type of healthcare provider has that in their toolkit. And this is the problem. I think increasing the allergists and immunologists are taking on this role. Clinical pharmacologists, dermatologists, pharmacists, nurses can all play a role in reassuring the patient on this account. And it's just education. And if we don't have providers that are confident having that education, then we need to work harder so that we do.
Can you expand just a little bit for the patients out there who have had reactions to other medications unrelated to the medication that originally caused their DRESS? We hear a lot about, I have these subsequent reactions to medications that I never reacted to before. And sometimes it's interpreted as being another episode of DRESS. Can you talk about that for a moment?
Yeah, unfortunately, when these occur, it can be very difficult because sometimes rashes occur in the absence of a medication after DRESS, and that would be considered a DRESS relapse. And sometimes there is a clear association with another medication, which ends up having, as I say, a temporary positive skin test or some other test is positive. But I guess the reassuring thing with these other reactions is they don't cause the full DRESS syndrome. They may cause, most typically cause a delayed rash, which is milder than the original reaction. And so we think, again, we need much more in the way of natural history studies to look at larger populations of patients to understand what happens over time. But most of the time, these are temporary reactions that involve rash alone, that don't involve serious organ involvement, and the patient can be reassured. Now, if something happens that is more than that, then you do start to get concerned that there could be relapse of the original DRESS reaction and that some other intervention will be needed in terms of adjustment of the treatment that the patient's on or consideration of another treatment.
Okay, so let's look down the road into the future. Is there hope for ways to better prevent, diagnose, and treat DRESS? What kind of breakthrough research could really make a difference?
I think the pipeline of that is vast, and I think there certainly have been a lot of advances over time. So one basic thing is at the drug development stage, certain chemical structures are more likely to cause these types of reactions. And at the drug development stage, those developing drugs for various diseases have actually do some basic work to actually define whether a drug is likely to actually mimic that type of structure or more likely to cause these types of immune reactions. And that process has improved over time. And so it's not like new drugs cannot cause these types of severe immune reactions, but they're probably in the big scheme of things less likely to do it than the drugs that were developed in the past. On all axes, whether that be prevention, earlier diagnosis, or targeted therapies, I think there's a lot of opportunities and a lot of research going on that will really change the way that we approach DRESS in the future, both during the counseling stage, where we may have the opportunity to actually develop personalized approaches to which patients receive which drugs and avoiding the risk of developing some of these immune reactions, to actually earlier diagnosis and stopping the drug as soon as possible and avoiding a lot of the longer term morbidities. And then, of course, the personalized therapy approaches that I mentioned. I think that when we start to understand diseases more on a cellular and molecular level, which the machinery for that has really been driven by areas outside of immune-mediated drug reactions, areas like cancer, for instance, we'll be able to eventually get there. But having the coordinated effort of investigators to get patients together so that the research can be done to really define this is going to be incredibly important over the next few years when we're developing the tools to get higher resolution on all of these issues.
Dr. Phillips, this is amazing. Thank you so much for sharing your expertise and everything that you do to help patients and families living with DRESS. Is there anything that you would like to say in closing?
I'd just like to say that I'd just like to thank you, Tasha, for everything you do to support the DRESS community. This is a wonderful initiative for National DRESS Syndrome Day, and I hope that these questions were meant to be thought-provoking in many ways, both not just for DRESS survivors and their families, but also for providers that are actually actively involved in the care of DRESS patients. And I hope that this stimulates thought and ideas of how we can promote better care of DRESS patients.
Beautifully said. Thank you so much, Dr. Phillips. I really appreciate your time and everything that you do to help support not only the patients, but us at the Dress Syndrome Foundation. It would be very difficult to do the work we do without the kind of support that you and, of course, the other medical providers, researchers give us. So thank you so much, and thank you for your time in doing this.
Thanks so much.
A wonderful thank you to Dr. Phillips for giving her insights today on some of the most common and truly most challenging questions surrounding dress syndrome. Her compassion and clarity certainly set the tone for today and everything we're hoping you all to learn and take away. So big thank you, Dr. Phillips. We did see some questions come in, so just a heads up, we will move to answer some of those questions after our next speaker, so we can get some perspectives there for you. So now we're turning to a critical area of research and clinical care, which is dress subtypes. The idea that not all dress cases look the same and that identifying patterns can lead to more personalized treatment. To guide us through this topic, we're here with Dr. Abraham Corman. He's a medical dermatologist at Ohio State University Wexner Medical Center. He's deeply involved in treating patients with severe drug reactions and studying their complex presentations. Welcome, Dr. Corman.
Thanks for having me. My name is Abe Corman. I'm a dermatologist at Ohio State University. I'm an associate professor. And here I focus on inpatient dermatology. So I direct our division of inpatient dermatology, where I manage a lot of patients with dress, probably around 30, 40 cases a year at least personally. So I have a lot of experience with it clinically, and then I perform research on this condition as well. It was hard to boil down a 5 to 10 minute talk on dress in terms of what I wanted to talk about, but I wanted to focus on one area of research that my group has done on the subtypes of dress. And basically what I want to impart upon you is the fact that we call patients who have dress, we kind of know this as a clinical syndrome, but there's more and more evidence that there's specific subtypes of it. So it's a little imprecise in general to say that 2 patients who have dress have the same type of experience or same type of findings or complications. And we know that there are different things that can predict how they react, long-term complications, et cetera. And so again, that's the main thing I want you to get out of this. I don't want to get too technical on this talk, but just the main things that not all dress is the same. And I want to discuss 3 areas that my group has published on where we found that there's different subtypes or phenotypes of dress. One of them was focusing on mortality based on race in dress syndrome. One of them is looking at cytopenias, which means your cell lines are depressed. And one of them is looking at a specific subtype where people with dress develop pustules, and it actually predicts their future chance of having a recurrence of dress. So the first study that we did was looking at dress based on race. And we have a big database here at Ohio State because we've seen a lot of patients with dress. And what we did is we divided it based on some of our older data. We divided patients who had validated dress syndrome based on whether they were white or African American. And we looked at their outcomes, and we actually found that patients who are African American had a higher risk of dying within 30 days. And so the takeaway here, and this hadn't been really published or known prior to these data, are that there are disparities exist even within dress, and patients who have dress who might be one race compared to another are not going to have the same outcomes. When I see a patient who's African American or maybe of even Hispanic ancestry with dress syndrome, alarm bells are high and maybe a little higher than normal because I know that the data shows that they do worse patients who are white. There's not a really known reason for why this is. There's some theories. I have some theories, perhaps maybe it's a little bit harder to differentiate clinically someone who has dress who has darker skin. So it can be a little bit harder to see their rash. Here's a good example I wanted to put up to highlight that. On the left is a patient of Hispanic ancestry, and our patient is on the right is a patient of white ancestry or Caucasian ancestry. And you can see that the rash of dress, because it's naturally red or inflammatory, is a little bit more prominent against white skin than it is against darker pigmented skin. So a theory I have without real evidence, just anecdotally, is that it could be due to delayed or incomplete diagnostics or evaluation of these patients just based on skin type. Another thing that our group showed is that not all dress is equal in terms of when it occurs in a patient's life. And so what we did in this study is we broke down patients by their age. So we know that it can occur across a wide spectrum. There's specific ages where it occurs more commonly, but we broke it down by age. And we actually found that patients who were older at the time, average age of 54, for example, were more likely to develop cytopenias. And this means that their cell lines were depressed and they would have a higher risk of complications. So again, we usually see DRESS in a younger-ish population, but it's not uncommon, especially with some of these medicines that incite or increase the immune system, that can see it in older patients as well. And so now, based on these data, when I see patients with DRESS who I diagnose above the age of 40, 50, we know that we want to watch them a little bit more closely in terms of their blood counts, and we look for any complications, because if these patients can develop severe leukopenia, meaning their white cells are down, they might have higher risk of infections. Another really interesting area of our research has been on the subtype of DRESS called DRESS with pustulosis. So basically, as you might know, there's different kind of flavors or varieties of how DRESS can present. In general, a person presents with a diffuse rash. Their face may be swollen, their ears may be swollen, they might have lymph node swelling, they might have liver, kidney, thyroid issues, a host of different issues. But what our group found is that there's a subpopulation of people with DRESS who might develop pustules, so they'll develop pus bumps on their skin. And I noticed this over years of taking care of patients with DRESS. Kind of wondered, well, does it mean anything? Is it relevant, or is it just the subtype happens to look a little different than the other? And we found that indeed it does mean things. And what it means is several things. So the patients who have these pustules or develop these pus bumps who have DRESS compared to patients with DRESS who don't develop it have a few unique findings. So typically they tend to be a little bit heavier weight. They tend to have more involvement within the folds. And they tend to have, actually, interestingly, a lower risk of liver involvement and a higher risk of a DRESS flare. So now we know, when we're looking clinically at someone who has DRESS, we're looking carefully for these pus bumps, because again, if we see that, I have a higher alarm bell, higher index of suspicion that they might have a higher risk of flaring in the future, and it might inform how I treat them. Perhaps a longer, slower taper of a medicine, closer monitoring, closer blood work, things like that. Here's an example of a patient who has DRESS with pustulosis. So you see this classic diffuse morbilliform, meaning measles-like rash, and they have pus bumps there on the neck and the folds. Here's a different patient who has this. Again, it's subtle, but over time we've trained ourselves to be able to see this, but you can see where my arrow's pointing. Hopefully you can see that. Pus bumps here on the chest and on the background of the diffuse kind of red rash. So this is another unique phenotype that we have to watch. So just because a takeaway, and I know I kept this talk short because I'd rather leave time for Q&A, we know that DRESS is a syndrome with multiple kind of subtypes to it. So we know African-American patients with DRESS have a higher risk of actually dying, mortality, compared to white patients. We know older patients are more likely to have cytopenias. And we know if we identify patients with DRESS and they have pus bumps on their skin, they have a higher risk of their DRESS actually coming back again. And so the takeaway for all three of these is that these are specific groups that need to be watched closely. Here are my references. They're all our group studies. And then feel free to reach out to me anytime. Thanks for having me. I'm happy to take any questions, Tasha.
Thank you, Dr. Corman. That was such an insightful overview, really understanding the nuances of DRESS subtypes. It's key to helping patients get the right care at the right time. And it was interesting, your point about DRESS on darker skin and identifying that and the potential for delayed diagnosis. We have a mother of a DRESS patient speaking here later who I think got very experienced with her son. So thank you. We have a couple questions coming in, and let's just take the first one. So a patient is saying that they were diagnosed with DRESS with a lot of the known clinical classical symptoms. Elevated eosinophils were not found. They go on to describe their other symptoms of fever and rash, swollen lymph nodes, extremely highly elevated liver function. So they're asking, is it possible to have DRESS without eosinophilia?
Yeah, absolutely. So if you look at the most widely accepted objective diagnostic criteria for DRESS called the Registrar score, which had been developed almost a decade ago now, eosinophilia is part of the point calculation for diagnosing DRESS, but you can meet full criteria without eosinophilia. So there's different reasons why you might have full clinical criteria. You might meet clinical criteria for DRESS without having eosinophilia that I can get into. Maybe it's a little in the weeds, but you absolutely can have full DRESS syndrome without eosinophilia, and I've seen it dozens of times.
Thanks. And then, so if the patient does not have eosinophilia, how is it differentiated from another condition if we're not seeing that as a factor, even though it's in the name of the condition?
Yeah, so you would need to meet the full other clinical criteria. So the extent of involvement, the latency period between starting the drug and developing the rash, where the rash is, some certain other lab markers that we look at, like liver function test damage, kidney damage, etc. So yeah, the E in DRESS is a little unfortunate. It's a feature that we see in the majority of patients, but you don't have to have it to meet the clinical criteria. So if you don't have it, it makes us a little less sure about the diagnosis. It makes it a little bit more challenging, but you can still render that diagnosis.
Okay, thank you. And I guess that's why some have started making the E in DRESS lowercase instead of uppercase, so we can understand that differentiation. We have a lot of comments coming in from people who are African American and say they've had DRESS. One question that's interesting is, do patients of Caribbean descent have the same concerns as African American patients?
I don't know, at least from our study, because from our study, the patients were demographically African American, so not like Afro-Caribbean or African. So I'm not sure, at least on my data, I can't say that they would have the same mortality risk. If you look from kind of piggybacking off of Dr. Phillips' recorded talk, probably, because it's probably based on some of the same common genetic and HLA subtypes. But from our study, it was just African American patients that we studied.
Okay. And then just a question that I have, when you were talking about the mortality rate for patients with darker skin, is there something there that could have to do with the type of medications that they're tending to take in that population?
It's possible too. The problem with our study is that the number was so low, we're not able to draw a definitive conclusion from that. So I think in our arm of patients who died were African American, it was 2, which obviously is really high, and that's not good, but that's too low to make any statistical inferences. So we can't look at the medicines that they took, look at the medicines that the white people took, and then compare it from that. So the short answer is possibly, but the longer answer is we can't prove it right now.
Okay, thank you. Okay, so here is a question. With a subtype of pus bumps, what is the likelihood of reoccurring, and would this reoccurrence be random?
So the reoccurrence rate, I think in our study was about 20 to 30%. I could look. So pretty high. Let me say exactly what it was. We found a recurrence rate of 31%. So 31%, I thought it was around there. And pretty high. 1 in 3 patients, if you have those pustules, could have a recurrence. Typically in DRESS, if we see a recurrence, it's due to a few reasons. One is that the patient is re-exposed to the same medicine or a medicine in the same class. 2 is the tapering of the medicine that they're used to be treated, which is usually a corticosteroid like prednisone. It could have been done a little bit too quickly. And 3 is that there could be viral reactivation, which I fortunately don't have time to go into that, where they could develop a reactivation of a virus in their blood. So there's not a good way right now to predict the percentage of people who's going to develop that. One group developed something called a redress score, redress like RE, where they validated a score that predicts the recurrence of people in DRESS. It's based on the age of the patient, their sex, whether their ANA was positive, things like that. But it's not widely used yet. I apply it to patients, and it's hard to predict who's going to recur. But we know if you have DRESS with pustulosis, it's very high risk.
Okay. And can you clarify what is the difference between DRESS with pustulosis versus AJAP?
So yeah, that's a good question. It's a controversial question. So AJAP stands for acute generalized exanthematous pustulosis. It's a drug reaction that typically occurs within 1 to 3 days of exposure to a medicine, where someone develops a diffuse red rash with pus bumps. So it's similar in a way to DRESS with pustulosis. For a long time, I thought that these patients probably had both. So they met full clinical criteria for DRESS, but then they also have these pus bumps and things like that. So they have some overlapping features of DRESS as we know it, and then AJAP. But we decided to name it as DRESS with pustulosis because they didn't behave exactly like AJAP patients. The time between starting the medicine and developing the rash was not the same. The way it appeared was not the same. And overall, they were closer to a DRESS phenotype than an AJAP phenotype. So Dress with pustulosis and HF both have rash and pustules. They're both due to medicines, but beyond there, really the similarities stop.
Okay, perfect. Thank you so much. Okay, so here's a potentially tricky question. I think a lot of patients and families are on here listening to you and to Dr. Phillips talk, and they're hearing how knowledgeable you are about dress, and that for some of these people has not been their experience in terms of being cared by providers who have this kind of deep understanding of dress syndrome. I think they're just looking for some guidance and someone who is well versed. How does someone who has been diagnosed with dress get the appropriate care, particularly when they're not in an area where they have access to somewhere like OSU or Vanderbilt?
Yeah, that's a tricky question. In general, you probably want to try to seek out care at a hospital that is like a tertiary or quaternary care hospital. So it means that it has access to all the specialists who have expertise in dress, specifically dermatology. So not all hospitals have access to dermatologists that come into the hospital and specialize in patients who are hospitalized for rashes and skin issues. Wanting to seek out major medical centers. Typically, major medical centers are the ones who have dermatologists who go into the hospital, but not always. Beyond that, you're going to want to go through organizations like your own, which can develop a physician's network of experts who have expertise in it. And then if you really want to seek out the people who are on the research cutting edge, you can look up who publishes in the condition. So you see what types of groups and what their background and who's publishing on these rashes. But yeah, it's difficult. It's difficult because unfortunately, if you're in a rural area at a hospital that doesn't have dermatology in there, you're unlikely to get an expert in that condition. And unfortunately, that just is what it is. A small bed hospital where there's no dermatologist.
Yeah, thank you, Dr. Corman. That's certainly been our experience in trying to support patients if they're calling in from Dallas or Boston or one of these cities where we know we have these institutions where there's a lot of knowledge. That's easy, but the rural areas are a little more challenging. Okay, you need to go to clinic, so we're going to wrap up with you. Thank you so much for being here. There are other questions that are coming in. Would you mind if we forward those to you at some point for answering and we can get back with you?
Yeah, absolutely. Thanks for having me.
Okay, thank you so much, Dr. Corman.
We're moving into our next talk, and we are very honored to welcome a joint presentation. We have Dr. Maria Cecilia Cavallo, an allergist and immunologist based in Argentina, and Laura Sellier, a dress survivor and advocate, also from Argentina. Together, they'll share a dress story through two lenses, a powerful reflection on the doctor-patient relationship and what it means to face this condition from both sides.
Hi, everyone. Thank you, Tasha, for this invitation. We are glad to be here to be part of this webinar on a day in which we get together to raise awareness about dress syndrome and also to honor those who lost the battle against it. So I'm Laura from Paraná, which is a city in Argentina, and I'm here with my doctor. She is Cecilia Cavallo. She's the allergist who diagnosed my dress in 2020. So we are going to tell the story of this dress journey together through both the patient's and the doctor's eyes. My dress journey, sorry, I'm trying. It's fine. All right. So my dress journey began in about a month before June 2020, in the middle of the COVID pandemic. And I had a rash. As a patient I have atopic dermatitis, so rashes were not new to me, but this one was particularly different. What I noticed about the rash was that it wasn't my usual eczema. The skin felt tight, and so tight, in fact, that I couldn't move. It was peeling everywhere. It was not just itchy. I experienced a pain in my skin, and it was a pain that I never felt before. So at first, I went to different doctors. In fact, there were 2 GPs and 2 dermatologists, and the last one noticed that probably I was having a reaction to some medication, so he referred me to Cecilia. At that point, I was taking Benadryl, levocetirizine, meprednisone, and zolpidem, which is a sleeping pill. I couldn't sleep, so in fact, I took 2 zolpidem pills instead of 1. But anyway, none of these medications seemed to be working. So, Cecilia, how did you know that this was a reaction to some medication?
I first saw Laura, I was immediately clear that it wasn't just atopic dermatitis. Her skin was extremely inflamed. She has severe edema and also a systemic symptoms that she described. She didn't just, it wasn't just a rash. I was affected her whole body. I suspect that a severe drug reaction was right away. So I ordered some urgent blood tests the same day. Laura have only half of them, the result. So she sent it to me that night. And I told her right away, it's going to follow you the case during the weekend. So we can check on that. She present arthralgia, actenia, erythrodermia, and in the blood test, they show eosinophils and they have the hepatic transaminase. They were really high. So right away we decided to get into the hospital and treat right away.
I also said that my skin hurt. So she asked me to send her some pictures, and these were the photos that I sent. As you can see, the skin was purple, even gray in some areas. So that is what I felt and the way it looked like.
Laura's case was really severe. She has a full body rash, small lymph nodes, high eosinophils counts, and the liver was involved. So everything pointed about its dress. Laura wasn't able to sleep, so that night the doctors gave her benzodiazepines with further altered life functions. Due to this worsening, we were going to admit her into intensive care for monitor and start treatment with hemoglobin. But we decided with the family to manage in the general ward. We did a pulse of corticosteroids, systemic, and irritation and antihistamine because she start getting better.
So during those 9 long days, I painted mandalas to distract myself from the pain. And we had this team that you can see in the photos.
Yeah, yes. Team is the key for diagnostic dress disease and the treatment. I work with the hospital staff, the dermatology, Dr. Valeria Frankel, anatomopathology, Dr. Basaldua. We have a psychodermatologist, Licenciada Venturini, and they help us together and we guide her through the treatment and the management of the symptom as soon as we suspect it.
In the pictures, you can see in the picture on the left, that is my dermatologist who worked together with Cecilia all along the process, day and night. They were not part of this center staff, but they guided this treatment. In the picture of the middle, you can see my psychodermatologist, that is a psychologist specialized in skin conditions. And in the day that picture was taken, we were delivering a presentation for doctors because I am part of the Atopic Dermatitis Association of Patients. And also in the picture of the right, we were with Cecilia on July the 16th last year on a local TV set, raising awareness here in our city about DRESS syndrome.
Yes, as doctor, we need to listen to our patient, not just the symptoms, but the patient's whole story. It's something that doesn't fit that usually patients. We need to be curious and not facts. So it's very important to guide the population.
To raise awareness among the population. And my message to patients and caregivers is advocate for yourself. If you feel that there is something wrong that if you don't have the usual symptoms, push for answers and keep seeing other doctors to find the answers that you need. This journey was quite long. It lasted about 8 months. And it is key to say that recovery is physical as well as emotional, because Dress syndrome left an emotional mark in my life.
Yeah, recovery doesn't stop when the rush revolves. Emotional is really important. Rebuilding trust with medication and long-term monitoring are part of it. So it's very important to keep on that.
And as the quote, for today's talk said, teamwork can not only make a difference, but also save a life. So it is also important for doctors to be aware of the fact that working with other doctors, with other specialists is very important.
Yes.
So this has been our journey through Dress. We are again thankful for being here, and we are open to hear your questions if you have any.
Thank you so much.
Thank you both, Dr. Cavallo and Laura. Let's see. If you can stop your screen share, we can perhaps see the
There.
screen. There we are. Amazing. Wow, that was such a powerful and moving conversation. Really, it reminds us so much how partnership between patient and provider, that trust on working together, can make such a huge difference. Lara, I love that you showed the photograph of your team. It shows that Dress really does take a team to get a patient through it, and how fortunate you were that you had such an amazing team in the care of Dr. Cavallo. You know, I think
And of course, my family and my partner were really important in this team. Their pictures are not there, but they were my support. Exactly.
Yes, we absolutely need the support of our friends and family. I think a question that we get a lot, and that someone is asking here, and perhaps you both guess it, we always say a patient really needs to advocate for themselves. It can be easier for some than others. If this is a condition that isn't well heard of, and of course you've never had before, how do you advocate for yourself? How do you know how to do that? And what are you, as a patient and as a physician, how would you advise a patient to advocate for themselves when they're questioning and don't feel like they are getting the information or the care that they need, or that their concerns are being taken as seriously as they think they need to be?
First of all, I think that only us know what goes on in our bodies, what feels normal or the regular way we feel, and if there is something different. Secondly, we have nowadays a lot of information. Of course, that some of that is confusing, but there are associations. For example, here in Argentina, as I've had atopic dermatitis all my life, I work together with them and I talk to them and I ask questions. Is this what you usually feel? Have you ever felt it this way before? And in fact, what I knew, but these people in a way confirmed that was not a dermatitis. Then, despite the fact that we were in the middle of the COVID pandemic, I kept on going to different doctors because I needed answers. And I remember the second time I met Celia, I told her, please listen to me, because that is what I needed. Someone who listened to the whole story. I am taking all these medications. Please, I feel that one of them is making me feel this way.
Yeah, and the thing is, like, any drug can induce stress. So it's really important to think about, and the patient knows, like, we always listen to, do you feel different? In the case of Laura, she has atopic dermatitis, so it's a skin that it wasn't healthy. So it's harder to make a diagnosis, because sometimes they think it's a flare, but she knew that the symptoms were different. And the diagnostic is not that hard if you think about it, because just with the blood test and with the skin, if you have the history of taking medicine, it's not that anyone can do it. But if we don't think about stress, The diagnostic, it started later, and then there were more complications. So I think everything helps doctors. Maybe because I'm an allergist, I'm not used to drug allergies, so it was clear for me. But we have to get aware for everyone, doctors in the emergency rooms, because sometimes they arrive late, and that's when we have to listen to patients, see that it's not going on. That is something that we have to take care really fast to avoid complication.
Thank you. And it's such an important point, Dr. Cavallo, about the medications. I wonder if, because Lara's medication was Zolpidem, which is not one of the highest on the list of frequent dress-causing medications, if that could have complicated her diagnosis or put dress less down the list of suspicion in her diagnosis.
Yeah, sometimes there we see it's not that common. There is few cases in the world with Zolpidem, but we know what any drug can do it. Now we have one with penicillin, amoxicillin, so we have to think about with any drug can cause it. And the same for doctors, we have to get trust to the patient to get under medication if he has to take other medication in the future, because if you know which one was the cause, you can advise which one you can have or not, or to make a program and yourself so Laura can feel safe taking any medication.
Perfect. So one more question, and then we're going to move on to the next.
Yeah.
Speaker. There's a question about, did Lara have many long-term complications and difficulty with flares on her treatment? And just to confirm, it was steroids that you were taking through the course of your recovery, correct?
I took meprednisone for 7 months. That was the period of the tapering. And then I was given a biological medication, but it was due to my atopic dermatitis, not due to stress. So I needed that medication for 2 years and a half.
Yeah, because the corticosteroids help her to the atopic dermatitis too, but it was for the dress that started. But it's really, you see, when you go through corticosteroid, sometimes patients were taken before and they decapitate eosinophils. So sometimes you see patients with a drug reaction in skin and blood test without eosinophils, but sometimes because they were taking corticosteroid 1 week before. So it's always, you have to check and double check if they are that of the eosinophils blood test, it's without corticosteroid system.
Got it.
And I was taking steroids before that.
Yeah. And okay, I know I said one more question, but there is one more question that I think might be important to address. Someone is asking if they've had DRESS and they are going to be given another medication that they're concerned about might cause a reaction. Is there anything that they can do preemptively?
What we can do before? No, because like sometimes you can predict if you will have a reaction. In case of they can do a genetic test that you prefer, but any drug can do it, and maybe you take that medicine 5 times in the times to start the reaction, so the allergy reaction. So we can predict, but if it's the same group of the medication or if it's associated with another pathologies, you have a high risk of allergy reaction, so you have to avoid it. But maybe you took some pill for hypertension for 10 years, and maybe in the year 11, you start making a reaction. So we can predict, but we have signs and the comorbidities, and if it's the same family of the drug, you know that you can do another reaction, so it's better to avoid.
Yeah. Thank you. Yes, we always try to advise patients if they're concerned about trying to figure out what medications are safe for them to take in the future, to see an allergist, immunologist, talk about what kind of screening or testing could be if it's
Yeah.
good. But allergist immunologists play a huge role in DRESS And
yeah, we did the skin test with the drugs, and you can check there. Yeah, for dress symptoms, we can do it. If you have NET or Steven Johnson, it's different, but we can check there, and we for sure know which one is the one.
Thank you both for the work that you're doing. It's wonderful that you had such a good experience for a terrible condition, but that you had a good relationship, and Larry, you had the support that you did. And thanks for the work you're doing there in Argentina to educate about Dress syndrome. And thanks for being here.
Thank you for inspiring me.
Yeah, thank you, Tasha, and everyone.
That really was a great conversation. Thank you so much. All right, well, that talk of allergy immunologist is right on point, because our next topic is with Dr. Matthew Krantz. He is an allergy immunology physician scientist and assistant professor at Vanderbilt University Medical Center. Dr. Krantz is working at the intersection of clinical medicine and data science. He's helping to lead efforts to make medications safer using tools like electronic health records, and how technology can help reduce the risk of drug reactions like DRESS. This is a pre-recorded talk, so we won't be taking live questions at this time, but please feel free to use the Q&A tool, and we're happy to pass along any questions you have for him to answer at a later date.
Hi, my name is Matt Krantz, and I am an allergy and immunology physician scientist and assistant professor of medicine at Vanderbilt University Medical Center. It's an honor to get to speak with you today on National Dress Syndrome Day 2025 as a part of the Faces of Dress program. My research and career development is supported by grants through the American Academy of Allergy, Asthma, and Immunology, as well as the National Institute of Allergy and Infectious Diseases. My primary mentor is Dr. Elizabeth Phillips. It's a pleasure to be highlighting some of the work that I've been doing using electronic health records to make medications safer, especially for patients experiencing severe drug reactions like DRESS. The first step in the work that I do that uses electronic health records, which are also linked to genetic information for patients in the form of DNA biobanks, is to identify patients who have experienced DRESS syndrome. Patients who experience DRESS syndrome are able to be identified using algorithms that look for the presence of allergy labels to specific medications that note a reaction of DRESS, the presence of billing codes that are associated with drug rashes or abnormal eosinophil counts, the presence of kidney injury or liver injury, many of these of which are criteria used to diagnose DRESS, or called the Registrar criteria. The second step of this work is to identify individuals who've received the same medication but have not experienced a severe drug reaction or are otherwise tolerant of that medication. By pairing individuals who've experienced DRESS with individuals who have tolerated the same medication allows for comparative studies to identify early differences that may occur in lab values that could be used for predictive models in the future for the early diagnosis and treatment of DRESS syndrome, so that patients are diagnosed at an earlier time so that their disease may be more mild and more treatable. The other comparative work that can be done is looking at genetic factors, which include HLA, as well as other genetic factors outside of HLA that in combination could be used to improve the positive predictive value of identifying individuals who are at the highest risk of developing DRESS syndrome to a specific medication. Through this work, the future hope is that a predictive model for the early diagnosis and treatment of DRESS based off of changes in routinely obtained laboratory values could be implemented in the background in electronic health records to prompt providers early to consider DRESS syndrome before symptoms become more severe. This way, the medication can be stopped as soon as possible and treatment can be initiated to improve outcomes for patients who experience DRESS. The other future avenue for this work is in prevention of DRESS syndrome in the first place. And this is by incorporating genetic testing that may be part of a patient's electronic health record and available at the time that a high-risk medication may be prescribed. This genetic information might include HLA information or other genetic factors that in combination may put individuals into a high-risk or low-risk category for developing DRESS. And providers, through clinician decision support, could be alerted if a patient's HLA and other genetic factors put them at high risk of developing DRESS, and would guide the provider to opt for a different medication or alternative that would be safer. Thank you for letting me share about the work that I've been engaging in with electronic health records and DNA biobanks in order to improve medication safety for the prevention and early treatment of patients who experience severe drug reactions like DRESS. Much of the work that I do is directly supported through patient participation in the DRESS Syndrome Foundation's DRESS Survivor Study. Therefore, I am especially thankful for the participation of patients and support of their families, and the privilege in getting to take care of these patients and their families as an allergy and immunology physician scientist. Thank you again for the opportunity to take part in the Faces of DRESS program on National DRESS Syndrome Day 2025.
All right, it's super helpful knowledge hearing the advancements they're making and understanding ways we can predict this. There's a long way to go, but a huge thanks to Dr. Krantz for his efforts there. All right, and moving forward, we're very honored to have Megan Garcia. She is a mother of a pediatric DRESS survivor, and her son experienced DRESS as a young child. Megan will share her story as a caregiver navigating this diagnosis and reflect on the emotional, medical, and logistical challenges families often face. We'll share a video of a conversation she had with Tasha, and then we'll welcome her live with a few thoughts, and you'll be able to ask questions.
I'm Megan Garcia. I'm very honored to be able to discuss with you guys and share my son Imperial's DRESS syndrome journey, what we have gone through to get our diagnosis, obviously what caused his diagnosis of DRESS, what we're going through currently, and things moving forward. I'd like to share hope with other parents and patients that may be going through this. You aren't alone. I hope you guys can find some hope in my story. Our story. So I am a mom of two boys, a 17-year-old and a 7-year-old, very busy with sports, after school activities and clubs, things like that. We are very family oriented. Definitely enjoy family. Family is key for us. So I am a certified peer support specialist. And with that, it is more recovery based in substance abuse and mental health. But I plan on moving forward with advocacy for DRESS syndrome and educating parents, patients, and really educating the medical community. I think it is crucial that we do that, and I feel like I need to use my voice for good. So Imperial is a super energetic little boy, loves Spider-Man, loves dressing up as Spider-Man. He is very charismatic. He's super kind-hearted. He likes to teach people things. So he's always teaching me video games and how to play the NBA game on Xbox and things like that. But he's such a smart, kind-hearted little kid. Back in August of 2024, it was actually the day before first grade started. Imperial had some blood in his stool. I took him to the hospital. He was admitted for acute colitis. It was suspected that he possibly had Crohn's disease. They weren't too sure after testing, kind of a wait and see kind of situation. And at discharge, it was decided that he would be prescribed the drug sulfasalazine. We started him on sulfasalazine 3 times a day, 500 milligrams. Imperial really never got better. So about a week and a half after being discharged from the hospital, we were there for 6 days. He ended up getting some swollen lymph nodes, as well as a rash. So I had took him to urgent care, and right away they swabbed him for strep throat. he was positive for strep throat. So immediately they assumed he had scarlet fever. I brought him home and he started antibiotics. Imperial was given amoxicillin. He was on antibiotics for, it was almost the complete dose. It was about 6 days. And like I said, he just didn't get better. His fever was continuous even after being on the antibiotics for the 48 hours that it usually takes to really start to kick in. There was about 2 weeks where Imperial was sick, and I was taking him back and forth between his primary care doctor and the children's hospital emergency room, basically begging for help. Imperial had started with a rash that started on his cheeks, that then spread to his arms and his chest and back area. He was very itchy. He's also olive toned skin, so his rash wasn't as visual as it would be on a fair-toned person, fair-skinned person. I would take him to the hospital and they were saying, oh, he has dry skin. This is why he's itchy. There was also some eye burning that was going on during this time, as well as some mouth sores on the inside of his mouth. So I'd also took him back to the ER to address these issues. And again, they thought it was allergies. I was basically begging them to please help my son. Something is wrong. It wasn't until he got worse, when it got serious and his fever was 104.7 and on the rise, that the emergency room finally took labs and saw that his liver enzymes were quite elevated. Imperial didn't present textbook for DRESS, as he did not have high eosinophils. So that was something that was throwing the doctors off. There was a number of things on the differential for Imperial: Kawasaki disease, MIS-C, multi-system inflammatory syndrome in children caused by COVID-19, HLH, systemic juvenile idiopathic arthritis. The list goes on and on. Acute liver failure. And it wasn't until maybe about the second day when Dr. Lebert, his current immunologist, came in and did bring up, hey, this might be the sulfa medication. During that 2-week period where I was taking him to the emergency room and back to his primary care doctor, I had suspected that it was sulfasalazine. And I had also brought it up to the prescribing doctor in GI. They thought because he was on the medication for a few weeks that it wasn't the medication. As we now know, this is the whole basis of DRESS, the delayed reaction. He underwent numerous tests, hundreds and over 500 different lab tests. They were concerned about his heart. He did have normal Gs. He had a heart murmur developed during this time. They were ready to do a liver biopsy on him, but thankfully his liver enzymes started to plateau, I guess you could say. He also did receive IVIG treatment, which did fail. At first it did seem to work, and then just the fevers and the rashes just returned completely. Everything was happening and at once, and it was so hard to explain. It was like unreal, I guess you could say. And at the same time, I didn't realize the weight of what was happening. I didn't realize his life was in danger. Finally, after rheumatology spoke up and said, hey, let's go ahead and do the pulse steroids. And he received 900 milligrams of Sol-U-Medrol 3 nights in a row. And finally, that stopped the fevers. That brought down the rash. It didn't completely make him better, but it made it to where he was stable enough to come home. At that point, we still didn't have a diagnosis. Things were still up in the air. Imperial also ended up presenting with joint pain, which is different for DRESS. So this is something different with Imperial's case of DRESS. During this hospital stay, Imperial continued to have a rash that covered his entire body. His face would swell, particularly his lips, to the point to where they had to bring an ambu bag in just in case. They weren't sure if, his airways were going to close. He was so itchy. He was so hot to the touch. We couldn't keep clothes on him during that time. His rash looks dramatically different than a lot of the pictures I've seen online. They're, I guess, not as alerting as some of the pictures that I've seen, but it's just real important. And I want to point that fact out of doctors paying attention to the skin tone. Sometimes it looks way different. As we're going through his eyes are burning. He's so fatigued. Once they give him the steroid, everything calmed down. We ended up getting discharged from the hospital on 60 milligrams of prednisolone every day. We continued on steroids until January of this year, quite a long taper. We finally did receive our DRESS diagnosis in December though, so that was nice. But imperial skin still is affected as well. Just recently though, we have had kind of a step back with the facial swelling. He still continues to struggle with facial swelling, extreme fatigue. He does still get rashes on his face, but since starting the Xolair, they've gotten tremendously better. He still struggles with pain in his feet. He's in physical therapy. He also has been diagnosed with migraines since having DRESS. Imperial is on a maximum amount of antihistamine. He's at 40 milligrams of Zyrtec daily, as well as cyproheptadine for his migraines, as well as nasal spray, eye drops, and we are still dealing with these allergic symptoms. We just don't know where things are headed. Hopefully he can recover fully from this. During the time that we were searching for a diagnosis, it honestly almost felt like I was going crazy. The doctors, I was in constant contact with them on patient portal. I took daily notes of symptoms, and the symptoms changed, and they changed in severity. Family and friends, I know they didn't mean any harm by it, but at the same time, trying to explain to them that my son is sick, we don't know what's wrong, but he's sick. And trying to explain that, and even to the doctors, especially to the doctors, emergency room doctors, it's tiring. Thankfully, we have a good team. We have a wonderful immunologist, Dr. LeBaire. I absolutely am so grateful for her. We have a great PCP. We have a great team, and I'm real grateful for them. And once we finally got the diagnosis of DRESS syndrome, it was like a weight that was lifted off of me, because I had known from the beginning in my mom heart and my heart of hearts that the sulfasalazine was making my baby sick. Most doctors have no idea what DRESS is. Every encounter that I have with a medical professional, I ask, are you aware of DRESS syndrome? And it's really the minority that know what it is. If somebody in the emergency room department, whether it have been a nurse, whether it had been somebody educated on DRESS, and sulfasalazine, people do know sulfa is a drug people have reactions to. I just feel education and awareness, even just the awareness, especially in Imperial's situation where his Crohn's diagnosis was only suspected, the medication wasn't necessary. So during the time that we were trying to taper Imperial off of the steroids, he would have relapse in symptoms. The facial swelling would come back, the itching, even the joint pain would get more severe. He was walking like he was a little old man in the morning times. And then when we would take down the steroids, it was so rough on him. So we would have to go back up. And when we finally got down to a low enough dose, it was to the point to where his mental health was more important. I finally was just like, hey, we're on this last little milliliter that we're on. Are we okay to just stop it? And thank God we were. We tapered within a week. Imperial's such a strong kid. I know he hurts, and where he hurts the most, I think, is he misses his friends. He hasn't been able to be in school like a normal kid. He will be going back into school in person this year for second grade. He is currently in basketball, which he loves. He does still deal with chronic foot pain, but like I said, he's so strong, he's resilient. He pushes through. So I do want to highlight the use of the Regiscar system. That system does work. That scoring does work. Imperial's was quite elevated, and with him not having the high eosinophils and him having just this different kind of presentation, that scoring system was so key into getting his diagnosis. It really works. I would really like the doctors to know that you can always learn something. We're all human. Educate people, educate your fellows, educate if you're in class, educate your classmates, educate your professors. Oh, everybody has room to learn, and the follow-up is important. The follow-up is very important. So if you're currently going through DRESS, or if you've been through DRESS, speak up for yourself. If you're not sure how to, reach out. We have the DRESS Syndrome Foundation. Tasha and her team and everywhere, we're all a big community. We're willing to help you recite what to say, or maybe even write a letter to the doctor. Hey, doc, I'm feeling this way, or I think I might need a little more testing, or speak up for yourself. Your story could change the direction of things for Dress syndrome. We need more research, and the way we get that is for all of us to speak out and share our story. Let the world know that, hey, we're here. Oh, and it's not just some random thing. Oh, this could happen to you.
Dress syndrome made things tough, but I'm tougher.
Megan, thank you so much for sharing that incredibly powerful story. And thank you to Imperial. He's an amazing kid, and you are such a great advocate for your child. It really resonates, I'm sure, with a lot of people, the difficulty that you had in getting Imperial's diagnosis, and it touches on a lot of things, from the original unnecessary medication that he took to the darker skin tones sometimes being more challenging to make the diagnosis, the lack of the eosinophils. There's so much in this story that I think are really important lessons. And we have a lot of comments coming in saying, "Go, Megan, you're a great advocate." Yes. Is there anything you'd like to say to people here live?
No, just thank you very much for this opportunity. I did want to point out the fact, something else that Imperial is dealing with long term is he is all of a sudden allergic to all kinds of things, dogs, cats that he was never allergic to before. So we are dealing with some immune dysregulation and things like that. So we are seeking any kind of help and knowledge that we can get. But we're here for you guys. If you guys are patients or loved ones, reach out. We're here to support you.
Yeah, thank you, Megan. I assume that he's being followed by allergist immunologist, and then looking for long-term autoimmune complications.
Yes, so we are working with an allergist immunologist, and we're actually waiting for an appointment with their multidisciplinary clinic at Phoenix Children's. They do have a allergy, immunology, dermatology clinic that we will get into. But yes, we are being followed by them as well as PCP very closely.
Thank you. This is an amazing story. We all hope that Imperial continues to heal, get better. The work you're doing and sharing this story is very important, and I think it's going to help people understand what families and patient go through, and good for medical providers to hear what the family experience is like. So thank you so much. We're going to move on to Dr. Nelson, but if you can stay around if there's questions, that would be terrific. Okay. Thank you, Megan. Deanna?
And moving on to our last speaker of today's webinar. Our last speaker today is Dr. Caroline Nelson. She's a dermatologist at Yale School of Medicine, and Dr. Nelson's been a leading voice in expanding our understanding of dress, especially when it comes to emerging therapies and how we can improve treatment protocols moving forward. Please join me in welcoming Dr. Nelson.
First of all, I just want to start off by saying what an incredible honor it is to be asked to join this Faces of Dress webinar today. This is my passion clinically and taking care of patients with this illness, and I am just so incredibly privileged to be here. I am going to speak to you about emerging therapies in drug reaction with eosinophilia and systemic symptoms, DRESS. My role is to be the director of inpatient or hospital dermatology at Yale, and I also direct our Grand Rounds program, where I speak to the doctors throughout Connecticut about this disease. So I don't have any relevant disclosures. I do want to let you know that in the process of this talk, I am going to speak about some use of medications off-label, meaning that they haven't been approved by the Food and Drug Administration specifically for DRESS. All right, so I have one major goal here, which is to review the DRESS studies in the literature with a focus on how cutting-edge research is leading to the discovery of new treatments. And I want to start off just by making sure everyone is on the same page about this really devastating illness. So it's classified as a severe cutaneous adverse reaction, and that is because it is a harmful and potentially life-threatening reaction. And the symptoms of it are not just limited to the skin. Of course, there is a widespread rash, and typically one of our clues is facial swelling, but there's also fever, elevated white blood cell count, classically eosinophilia, although I am going to talk about that, a lymph node swelling, and then major organ involvement, and especially the liver, the kidneys, and the heart. And the rash can look like a lot of other diagnoses. And so that can sometimes lead to a delay in the diagnosis. We do know that the drugs that most commonly cause DRESS syndrome are seizure drugs, antibiotics, and allopurinol, which is a treatment for gout, but many drugs can cause it. And seeing a little bit on treatment today, when we see a patient with DRESS, one of our first actions is to create a drug chart that extends 8 weeks back from the time that the rash started, and that includes everything from over-the-counter drugs to prescription drugs to vaccines and radio contrast media, everything to be as comprehensive as possible to identify the culprit. And then for mild cases, sometimes we'd use a steroid cream. For severe cases, sometimes we use an oral steroid or intravenous steroid or other therapies, and that's where I'm going to focus today. So we'll circle back to this concept. I did just want to mention that in the historical kind of quoted mortality rate from DRESS was 10%. We do seem to be doing better in more recent studies, which is good news, but it's still not good enough, 1 to 6%. And then our leading cause of death is hepatic necrosis, which means a failure of the liver. And unfortunately, we also know that DRESS has a high risk of relapse, and that can happen even after the drug causing the problem is stopped and before the steroid dose is reduced. And actually, our last speaker spoke about this issue of multiple drug hypersensitivity syndrome, and that's when a patient develops an allergic reaction to 2 or more unrelated drugs or develops other allergies, and so we have to keep our antenna up for that as a potential cause of relapse. The long-term impact can be severe. It develops in about 5 to 15% of DRESS patients, usually within 2 years, but it can be delayed more than 5 years. And the most common would be organ failure in older patients versus autoimmune diseases in younger patients, and especially autoimmune thyroiditis, but many have been reported. This is a busy slide, but I think stepping back from it, that the first thing to appreciate is how complex the immune system activation is in DRESS, and it happens differently in every patient. And so I want to go through this, just breaking down the key components of the response, because I think it's really important to understand the biological basis as we move into the new treatments. So when a drug exposure occurs, it breaks down into an allergen, and that allergen is taken up by an antigen-presenting cell, which is really designed to present information about infectious organisms, and in this case, allergens, to T cells. And T cells are responsible for protecting the body against infection and also patrolling for cancer. So they're very important cells in our immune system. But in this case, they have a dysfunctional response. And there are multiple different categories of T cells that are activated in DRESS. And I want to draw specific attention to these Th2 cells. The Th2 cells are responsible for activating eosinophils, hence the drug reaction with eosinophilia and systemic symptoms. And these eosinophils contribute a lot to the skin and organ damage that occurs in DRESS. But again, as our last speaker talked about, they are not universally present, and people sometimes forget that, and that can lead to a diagnostic delay. The other cell that I wanted to focus on is this T regulatory cell at the bottom here, which actually, in the face of all of this normal immune activation, is actually leading to immunosuppression. And when that immunosuppression takes place, viruses that are latent in the body have the opportunity to reactivate and contribute to the organ damage. And that's still a little controversial, but there's some evidence to suggest that is a real factor happening in patients with DRESS. So now that we've explored this, I want to return back to treatment and talk a little bit more in depth about how we treat DRESS. So there was a multi-center study of 391 hospitalized patients with DRESS in the United States. And in that study, 84% of patients were receiving either steroids orally or through the vein, intravenous. And so this would really suggest that we have a pretty monolithic or uniform approach to the treatment of DRESS. But there are complications. So while systemic corticosteroids remain first line for DRESS, they're our first choice therapy, they have some serious side effects, and that includes lowering the ability of the body to defend itself against infections. Also, weight gain, swelling, increased blood sugar, high blood pressure, bone thinning, fractures, mood changes, sleep disturbance, skin thinning, stomach and other digestive tract ulcers, and vision loss, including cataracts and glaucoma. There was a trial that tried to compare skin-applied steroids with systemic steroids in looking at patients who did have moderate DRESS, meaning that they did have this organ involvement. And there was not a clear difference, possibly because the study didn't include enough people, but it was important to note that 23% of the patients got worse who just got the skin-applied steroids and needed strong steroid treatment by mouth. And there were not differences in side effects. So this is a very important study that was published in 2023. It's a Delphi-based international consensus, meaning that experts got together and categorized patients into mild DRESS, moderate DRESS, or severe DRESS. And one of the implications of these categories was to try to say if you had mild DRESS, you could get topical corticosteroids, very high potency, very strong topicals, versus if you had severe DRESS, you really did need systemic corticosteroids. And then if you were moderate, it was a more of a gray zone and where the clinician would need to weigh in. But this became an important and helpful tool beyond just the registrar to help us say, do you have DRESS? It's also what severity of DRESS do you have to try to help target the right steroid treatment. Now, what about a clinician quandary, and I face this frequently, how to treat a patient who does not respond to steroids, is unable to taper off steroids, or cannot tolerate the side effects of steroids. And this is where we get into steroid-sparing therapy, and I put this list on the left, but what I want you to appreciate is the level of evidence is very poor. So a randomized double-blind placebo-controlled clinical trial is a study where people are randomly assigned to different groups, and neither the participants nor the researchers know who is getting the real treatment or a fake one, the placebo, to make the results more reliable, and this high-quality evidence is currently lacking for DRESS. So I'm going to talk to you about these therapies, but I think that's a really important point to keep in mind. So let's start off with a treatment called intravenous immunoglobulin. So how does this work? The idea is to boost low antibody levels, which helps the immune system fight off the reactivation of herpes virus. And this also seems to have immunomodulatory properties, meaning it alters the immune system to help be anti-inflammatory. And there was a study done at multiple hospitals, and this was a study where everyone knew which treatment was being given. It unfortunately had to be stopped because 5 out of 6 patients had serious side effects and 4 of them needed backup treatment with oral steroids. So intravenous immunoglobulin, the big takeaway, alone, we don't recommend it, but it might help when used together with steroid treatment. Another medication is cyclosporin. So how does this work? It stops cytokines. Cytokines are signaling molecules that those T cell populations put out to orchestrate their effects, and this blocks cytokines that cause inflammation, and in particular a cytokine called interleukin-2. And this is our highest quality evidence. There was a study that looked back at 5 patients who were treated with cyclosporin, and they looked at 21 similar patients based on age and sex who were treated with steroid, methylprednisolone. And what they found is that the patients on cyclosporin got better faster and spent less time in the hospital. And we do have a subsequent study that showed similar results in children. But it's important to note that this is a retrospective look-back study, and sometimes those studies can be biased. So the next one would be interleukin-4 and 13 inhibition. Most famous drug in this category for DRESS currently is dupilumab, and all we have here is some successful case reports and series. And then interleukin-5 inhibition, and again, this is case series that show us that some patients can get better quickly with fewer eosinophils and needing less steroid medication. One thing that's important to note is that these are more specific to that eosinophil pathway in the immune system, so they're not necessarily going to block all of the types of T cell activation, but they might be helpful as steroid-sparing therapies. And then finally, Janus kinase inhibition, and this blocks a whole bunch of cytokines that T cells put out. And there have been case reports, 2 patients with heart involvement, and then some patients with prolonged DRESS, which didn't respond to medications. And I did want to draw your attention specifically to this really important study published in Nature. This was a detailed gene study on skin and blood with a patient with really hard to treat DRESS. And they found that this JAK-STAT pathway could be a good target for treatment. And they also found the human herpes virus DNA in some T cells. And so they used one of these JAK-STAT inhibitors called tofacitinib together with an antiviral valganciclovir, and they were able to control the disease where many other therapeutic options had failed. And I think this is important not only to say this case got better with a JAK inhibitor, but really because I see this as the dawn of personalized medicine in DRESS, or the first application where an individual patient's cells were studied in order to figure out what treatment would be best for them. And so one of the things that we're doing at Yale is I collaborate with William Damsky, who is my basic translational research colleague at Yale, who does this technique called RNA in situ hybridization, and using that to detect and localize specific molecules. And we can use this to help guide treatment. This is an example of a patient where we tested the skin biopsy, we published this case, and we're able to show those activation of IL-4 and 13 and have successful improvement with dupilumab. So I think that's the holy grail going forward. This is my last slide where I want to mention that we've recently conducted a scoping review looking at mental health outcomes. And it's important to note that 36 to 63% of DRESS survivors screen positive for anxiety, 50% for depression, and 50% for post-traumatic stress disorder. And there's also other adverse psychosocial outcomes like quality of life, fear of medications, altered relationships with medical providers. And we are currently performing a Delphi consensus of international experts to develop a screening tool to identify at-risk patients. So my key points would be that we did have an international group of experts creating guidelines that help classify DRESS as mild, moderate, or severe. And this is going to help doctors decide whether to use these strong steroid creams versus steroids that could affect the whole body. We also have a lot of new drugs that are in the pipeline that we are gathering data on and hoping that we can use these advanced methods like RNA in situ hybridization to help choose the best steroid-sparing treatment for each patient. And finally, that it's important to take care of both the physical symptoms and the emotional well-being of patients to support holistic healing. So again, I just want to thank you for your attention today. This is my network of collaborators. I'm exceedingly grateful to them and to you for this opportunity. So thank you to the DRESS Foundation, and I'd be happy to take any questions.
Thank you so much, Dr. Nelson. That was such a beautifully clear presentation on DRESS and on the emerging therapies. It's nice to know that there is hope for better treatments. One of the questions that we have, how does a physician make a decision or know where to start with a DRESS patient in terms of what therapies to use?
So there's a couple of things. I think one thing that we do use empirically, if you will, at the beginning in a severe, if we classify a patient as having severe DRESS, is we do start off with systemic steroids. If they're, just because we want to bring that under rapid control and make sure that we protect the function of the organs. And there is also some evidence that getting steroids early in the course can decrease the risk of autoimmune disease later on. And so one of the things that we do here at Yale, it's not universally done, but because we have a special program devoted to this, is that we also send off a cytokine panel from the blood, and we will use that cytokine panel information as one factor to help us later on try to think about what steroid-sparing therapies might be helpful for that patient. So I mentioned the personalized medicine technique from the skin biopsy, but there's also the blood that can provide helpful information. And so we will use a variety of these. And also, finally, we have to take into account the patient's side effects as well as their comorbid condition. Do they have diabetes? Things where having high blood sugar is a significant problem. Are they struggling with depression and steroid is making it worse? And so we try to factor that in, all with the patient preference in this sort of bidirectional conversation to individualize the treatment plan for every patient. One of the reasons that I care about DRESS is, and one of the reasons that it attracted my interest as a physician, is that I saw that in psoriasis and atopic dermatitis, there's happen, this explosion of these very targeted, let's say less consequential treatments to the rest of the body. But in dress, we just kept always using steroids and these long courses. And it seemed to me like we had room to improve. And so that was really what drew me into this space.
Thank you, and I could not agree more. So many patients we talk with who have had long-term treatment with steroids, like you said, can have so many different issues associated with that and difficulty coming off the steroids. So it's good to know that there is hope. So what, if you could speak for a minute to what are the barriers to getting these treatments like the interleukin inhibitors and JAK inhibitors to be used more readily with dress treatment?
Yeah, I think that one of the barriers is having a kind of a dress champion in the hospital, because I've had meetings with pharmacists where I've had the opportunity to tell them how important it is to be able to have access to dupilumab or some of these other drugs in the mepolizumab in the inpatient setting. And that usually requires some advanced discussion with pharmacy to make sure that they're in the hospital and they're able to be given. And then in the outpatient setting, as we're looking at continuing some of these steroid-sparing treatments, I think insurance barriers are important. So going through appeals process, because these drugs are not necessarily FDA approved, going through the appeals process, presenting the literature. And there I actually do find that the personalized data that we get in terms of the cytokine panel from the blood, in terms of the skin biopsy, can sometimes be really helpful for convincing insurance companies that what we're doing is valid and appropriate for the patient. And that, and just putting more and more studies into the literature. Part of the reason I wanted to publish that case report on dupilumab was that next time we need to, somebody out there, some physician wants to try to get that. If they think it's the right thing, they can pull that case report up and say, hey, there's some evidence backing this. But the higher the quality, the trials we are able to do together, the better access we will have to these medications, and also our better understanding of who they are right for and who they are not for.
Yes, thank you, Dr. Nelson. The work that you're doing and that your colleagues are doing on these treatments and dress in general is tremendous and has made such a difference. And we have a comment coming in from someone saying, oh my, the psychological data is so validating. Thank you so much for sharing this. I feel very seen. Yes,
I'm so glad. It is an aspect of dress that I feel has been really understudied. And I hope that if we can develop this screening tool, that we'll be able to help people feel that validation and get the help that they need. So that means a lot to me. So thank you.
Yes, it's validating to hear from physicians that you're thinking of this and recognizing it. So thank you. We could go on for 2 hours, but we can't because we've got to wrap up. We have a lot of other questions, and we're going to forward some questions to the physicians that weren't able to be answered here today. We have so many, and we appreciate it so much. But we've got to wrap up. This has been amazing. And I thank everybody for being here. I'm going to let Deanna run through a few things, but just know that we're grateful for you, for the patients, the loved ones, the healthcare providers for showing up today. Thank you. Go ahead, Deanna.
All right. Yes, Dr. Nelson, that was wonderful. Thank you so much. And I echo Tasha's sentiments. It's been wonderful to have you all here today and spend your time with us learning and connecting. It's a close community, and we're glad you're a part of it. We wanted to leave you with some resources. So there's a lot of QR codes. We'll drop it, a PDF for you so you have a resource to take away. But we want to do some call outs. One is we have an awareness ribbon. It was designed in collaboration with our community, our dress syndrome community. So it's free for you to download and use however you want. We have ongoing dress support meetups for patients, loved ones, and caregivers. And we are scheduling our next date. It will be happening soon. So please go to our website and stay tuned. Check out our social media. We'll be announcing it. We've recently launched our dress syndrome swag. So you can go to our website and support our mission, as well as help spread awareness about dress syndrome. There's shirts and tote bags and various things available. And then importantly, we have Dress Hero nominations open right now, and you can nominate
medical professionals who, if you know of someone that helped you or a loved one or a friend, nominate them to be a dress hero. They're open worldwide, and nominations close tonight at midnight, right before midnight. So be sure to get those nominations in, and you can nominate more than one person. If you are interested to share your case with us, we have an ongoing Register Your Case survey. This helps informs medical understanding of Dress syndrome. And we also present you with opportunities to be connected to other studies should they become available and you wish to participate. So please feel free to register your case with us. And we also have Dr. Elizabeth Phillips, you heard from earlier today. She opened today's session. She has organized an upcoming SCARS workshop. So SCARS is severe cutaneous adverse reactions to medications. And it is for DRESS and SJS and the 10 community of medical providers and patient community. So more details coming. And as you heard today, with some personal stories of DRESS, they really do make a difference to help inform the experience of having DRESS syndrome and overcoming it, surviving it, everything that it goes into this complex case of DRESS. So please, if you feel inclined, please share your story with us. We will help in our awareness campaigns and make sure that people better understand the nuances and the subtypes that we discussed of DRESS and have your story shared. And as one of our DRESS syndrome patient community patients has said, every sufferer of DRESS has a different symptom and timeline trajectory, their own unique story to tell, as do you. And as a wrap up, I thank you. We're stronger because of you. It truly takes a community, and especially when you're dealing with a relatively unknown severe condition like DRESS syndrome, the more we are together, informing each other, connecting with one another, and honoring each other's experiences, we are stronger together. So thank you for being here, and thank you for your expertise and your knowledge and your stories.
Okay, and that is officially a wrap, everyone. Thank you so much, and take good care.